All right, let's try this today. So last week was the last opportunity you had to take it easy in this class. That's over. This is the hard stuff now. So um, this particular set of rhythms, atrial rhythms, is where most students have trouble in lab, most students have trouble on the exams, and most students have trouble in the field. Okay, so know that going in. But if it's proficiency, well, I'll try to get rid of some of the confusion. One, you might have a hard time recognizing the rhythms, and there's a lot of rhythms in atrial, a lot of them. Not all of them are emergent, but there's a lot of them that are testable. So obviously, that's one of the first challenges is getting the rhythm right. And then once you get the rhythm right, there are differences in how we call these rhythms based on rate. And then there's also differences in how patients present. And those differences are somewhat nuanced, but that's how you'll determine which pathway and treatment guidelines to use. So we won't finish all atrial rhythms today. I don't know that we might get through AFib and AFlutter. We'll probably do SVT on Wednesday. But for the most part, SVT's treatment, the way I like to keep it separate, Kathy keeps it separate in her videos, SVT treatment is different than the other rhythms we're going to talk about today. And really, aside from SVT, the other rhythms that are emergent are generally going to be AFib and AFlutter. But yeah, they're not always easy. So first I want to talk about a little bit of a farm review. Okay, you have farm resources, you have a farm exam coming up later in the term. Not really new stuff, but you will have more on the farm exam about scenarios and patient presentations because you'll have learned about those things in this class, treatment pathways and such. But it is going to dig up some old stuff, right? So let's start with that. Then we're going to talk a little bit about just revisiting some basic concepts, and then we'll look at the Huff book and go through some rhythms. So if we're treating medically today on the things we're talking about, if we're using medication to treat the patient, we're assuming that what we'll talk about a little bit later is we've identified that the rhythm's the problem, because the rhythm's not always a problem. But if the selection of rhythms we're going to talk about today are the problem, but they're not completely unstable, and I'll go through all this in a minute, if they're not completely unstable, then we may have the choice of using medication. And that medication is primarily going to be a calcium channel blocker. So calcium channel blockers, this is totally my day. This is how it's going already. Since 4 o'clock. All right. Okay. So calcium channel blockers are not in the state scope for 911 admin, but they are in the national scope. And so I would like you to, even though you know how it's going to end when you get your license, even though that's the idea, you're going to be tested on it at National Registry. You're going to be expected to use it in your scenarios, and you will have the opportunity in a scenario at National Registry, if it's cardiac and atrial and maybe symptomatic but not unstable, you might have to utilize this drug. So the assumption is that you can use this drug in all of our training, and then you'll just not use it when you're in the field. That's the idea. It would be a nice thing. I don't actually remember why, because we've had calcium channel blocker as a IFT drug for a long, long time. I don't remember exactly why we don't use it in the pre-hospital setting in New Mexico, probably based on need, but and that need is probably based on Albuquerque's transport times, not the rest of the state. But for some reason, we don't use it on 911. Calcium channel blockers, of course, block calcium channels. Easy, right? What's our prototype? Diltiazem. Okay. And diltiazem as a calcium channel blocker, we know that when we depolarize a cell in the heart, calcium's in this area, right? Phase 2. And calcium being released results in contraction if all other things are going well, okay? So for our purposes, don't worry about that because we're talking only electrically at this point, okay? The reason is calcium channel blockers only really work electrically, rhythmically, on particular rhythms that originate from particular cells. Anybody remember what cells those are? Nodal tissue, the pacemaker cells, primarily pacemaker cells in the atria. So we're going to be using this electrically to slow things down. So the idea here is that calcium channel blockers will block calcium channels, yes, specifically in the SA node and or the atria. The SA node, the pacemaker cells, even some secondary pacemaker cells, if we stop the release of calcium by giving calcium channel blockers. It's not, the doses we give won't necessarily impact the muscle side of things as much because there's enough calcium for contraction to generally occur anyways in the muscle. But it will slow the rate, because what happens is if you have a really fast rate, and right now we're talking atrial, so it'd be narrow QRS, you have a really fast rate, and it's so fast, think like how it's used in New Mexico. You probably have an intercept with a facility that maybe is a clinic somewhere. I mean, it's happened to me a lot of times in the reservation areas, and the doc can't tell what the rhythm is, so they slow it down with calcium channel blockers. I know you'd really only want to do this if you're pretty sure it's an atrial rhythm, but when they give it, it's going to decrease the conduction rate through those pacemaker cells. And one of the things we'll talk about today is that on some rhythms, so let's talk about AFib, which we'll define in a moment. AFib can have, an A flutter can have atrial rates 400, 300 beats per minute. And the AV node does its job by blocking some of those from conducting down into the ventricles. So the ventricular rate should not be the same as the atrial rate, as long as the AV node is working. But with that fast of a rate, it's hard for us to discern some things, especially if the ventricles are getting faster. If they're above 150 beats per minute, they're getting close to 200 beats per minute. So we give this drug, it decreases the rate of conduction, slows their, whatever the pacemaker cell is, could be aberrant in the atria, slows that rate down. And if we slow it down, then we're hoping, again, mechanical and electrical aren't connected, but if we slow it down, we're hoping that if there's less electrical impulses in the atria, less will go through the AV node, assuming the AV node is working, and will slow the ventricular rate. So if this patient is symptomatic, meaning they have probably a low blood pressure, but their LOC is not hemodynamically unstable, they have symptoms of having poor perfusion in their heart, for example, then if we slow that down, then we should get more ventricular filling time if we had a rapid ventricular rate. And more ventricular filling time on the mechanical side of things gives us bigger stroke volume and hopefully better cardiac output. And again, it's a medication, so it's the least invasive method, right? If we have a really fast rate and our choice is hemodynamically unstable, we're probably using electricity. We're probably getting to the advanced level. So remember that the calcium channel blocker primarily works to slow atrial conduction rates. That's about it. I mean, you know how to manage it if someone overdoses on calcium channel blockers. Give a calcium prep. Patients are on calcium channel blockers frequently, especially if they have rhythms that we're going to talk about today that they know about. But it could be a good tool if we had it. And again, I've never pushed it. I've administered it when I flew, but someone else made the order. I just made sure it was okay as we were giving it. So I don't have any experience giving it, but I have seen people give it to slow rate. And there was a time it didn't work out well, but most of the time they made the appropriate choice. And then from that, they decided, okay, it's this rhythm, let's do this. You probably won't be in that boat because you're going to be very proficient at ECG. So you're not going to need this to slow the rate down, but it does get harder and harder as the rates get faster. Okay, let's see, another thing. So we talked about the AV node. We're going to talk about the AV node today because that's the thing that's helping keep these patients from being hemodynamically unstable. What were the three roles of the AV node? Can you remember? Slow down conduction. Yep, slow conduction. In this sense, this would be to get the atrial kick, which gives us increased stroke volume, which equals increased cardiac output, equal increased blood pressure. Okay, 2, what else? Okay. And we're going to talk about some rhythms that are coming from the pacemaker, the AV pacemaker. And the third? Perfect. Gatekeeper, I think, is the perfect way to say it. Whereas Kathy, I think, will say, like, it decides. I got a bunch of beats. This one, this one, this one, no. This one can come through. So that's its gatekeeper function. And if the AV node is functioning, that might be what's keeping these patients from having a ventricular rate that matches their atrial rate, which would be catastrophic because it would be basically like having a really fast VTAC or VFib in its actual practicality. If the ventricles are moving that quickly and they're not pausing enough to fill with blood, then cardiac output just goes away. Okay, good. All right, what else do we want to talk about? Oh, and then ECG stuff. Again, lead 2 today. Okay, remember the rules. In any lead, as long as you know your orientation, a positive waveform is moving which direction? If it's a positive waveform, it's moving towards you, right? If it's negative, away from you. And if it were biphasic, and that was because of your view, This means you're kind of seeing it go in both directions. So think like I'm looking at it at the middle, and it's going either towards me and away from me, but I'm seeing it in the middle. So I see some, in this case, some towards me, some away from me. So biphasic. Could be passing you by. Just like you're standing on the side of a highway and you see a car coming, you hear it get closer and closer, and then you see it pass you and it gets further away. That's what this is likely telling you in some views. So keep that in mind, because one of the things you're going to have, a skill you're going to have to use in rhythm recognition, we'll use our steps. And if you don't use the steps, you're going to miss some things, as I'll highlight today. But in these views, you're going to be looking at abnormal P waves, because if it had a normal P wave, it would be what kind of rhythm? Be sinus. These are not sinus rhythms. There may be sinus involvement. That's different than the sinus is in control. There may be some sinus involvement, so sometimes we maybe get nice P waves, but usually not really. And they're going to look different. They might look inverted. They might look biphasic. They probably won't be absent, but they'll be, aside from fib, so there might be fib waves instead of P waves. Okay, so keep these things in mind as we look at the rhythms. And there are some interchangeable terms, so keep that in mind for your practice in the Huff book. So I'm going to start kind of like least emergent, just as Kathy did in her videos. And then we'll make our way to the emergence. I was thinking today I'm not going to use the projector. I'll just draw on the screen, on the whiteboard with the screen. Okay, so we'll start with, I won't go through the reading of the atrial rhythms, but it discusses the three major types of dysrhythmias. Make some room. Okay, I'll come back to the waveforms. I'll come back to the AV node. And we'll talk about treatment as we go through them. All right, and this is the 8th edition, but the chapter's number is the same, just page numbers are different. Okay. All right, so if it's helpful, you could look at the diagram that's above this that shows, there we go, that shows the orientation point or origination point for some of these, but it's just an example because it could be really anywhere in the heart. Like atrial fibrillation won't be in that one spot. It'll come from a variety of different areas, but these will all be above the ventricles. So what do you expect their QRSs to look like? Narrow. They look like they come from the atria. Good. The thing that will be different is the P wave. Okay, so here's a couple examples of abnormal P waves. And one, it's kind of hard to tell if your rhythm has all the same looking P wave morphology. If it's kind of pointed, it might be hard to tell if that's actually coming from the SA node or not. But when we see it among other beats, it's easier to pick up. And again, this gets really complex. Like you can have PACs, you can have non-perfusing PACs with just a P wave and a QRS. And those things make it hard to tell when we add other rhythms to it. So if you see a 12 lead specifically, unless it's in testing because you won't get another version. But if you're in the field, if someone gives you a 12 lead and you haven't seen the 6-second strip, try to get the 6-second strip or longer, because in a 12 lead, it's very hard sometimes to tell what the underlying rhythm is when you get the little snapshot of every camera angle. Because what might look like a P wave from a non-perfusing PAC in one angle might actually be telling you, if you had the whole strip, that you have a 3rd degree block or some variation of a 2nd degree block that we'll get to later. So right now I want you to focus on imagining that we have nice rounded P waves in most areas, and you'll be comparing this to other pieces of the puzzle. But these are different versions. So we can have a peaked or pointed P wave. This is kind of a biphasic. They call it squiggly. This is inverted. What does inverted mean in the way the waves are going through the heart? This is all E2. So P wave should be upright, which means in lead 2, it's coming towards you. So if you see an inverted P wave, what does that tell you it's coming from? It's going backwards. It might be coming from the AV node, but it's moving away from you because we're in the same lead view. So that means that the atria is depolarizing maybe from the AV node, going back up towards the SA node, going through the pathways, or somewhere else in the heart or in the atria. But what do you think that will do? Because remember, we squeeze, contract, if mechanical is connected, we squeeze and contract the muscle in the same direction that the electrical depolarization occurs, because we can't have a contraction without depolarization. So if depolarization is going backwards, how will that impact cardiac output? Let's say it starts in the AV node, not in the SA. It'll decrease it because stroke volume would be decreased, because if we have a backwards flow, we don't have an atrial kick. The atrial will squeeze, but it'll squeeze from the bottom up, which would be the opposite direction we need it to, or the same direction the ventricles would squeeze in. These are instances, and we'll see a lot of these. We might have seen, I don't know if we saw some of these in sinus, but as the rate gets faster, the space between each beat gets compressed, and because of the amplitude of the QRS and the T wave that the QRS generates, that can kind of stack over our P waves, in which you really can't necessarily discern them. So what this is telling you here, again, because they know it, is that this T wave and this P wave have intersected. The P wave's in there, who knows what morphology it is, but the T wave has more amplitude, even just in repolarization, than the P wave would generate, or the atria would generate. So the T wave is dominant. Almost like if we're looking at a normal rhythm, we can't see repolarization of the P wave or the atria because it's buried under the major amplitude of all the cells of the ventricle that are depolarizing. Here it's repolarizing. So it's sometimes difficult to tell, hence maybe somebody needs to slow that down to be able to discern. Now, to say that it's a TP wave is guessing that this QRS, because really you can't really see a P wave in there, it's all dominated by the T wave. Sometimes you get a little extra bump. This looks a little bit like it. This is part of the P wave, and there's a T wave going down. And that makes sense because this part of the T wave is basically the end of repolarization, so it's finishing its work. The electrical amplitude is going back to normal, so you can see a little bit of that, but you can't really make it out here, maybe a little harder here, but you can see the P wave here. So if you can't see the P wave, one of the ways that you'll determine this, if it's really fast, and you know that's why you can't see the P wave, is you wouldn't have a narrow QRS unless you had an atrial origination. And it's very common that if you have a narrow QRS that the P wave's involved. You're guessing though. Maybe there is no P wave. Maybe it's coming from somewhere else, or maybe it's a transformed or abnormal P wave in that presentation. So you're making a guess, but that QRS couldn't be narrow without atrial involvement. So you're guessing that the T and the P wave are intersecting. When I slow this rate down, if I have to slow this rate down, and maybe it's not electrically, maybe it's not even chemically in the sense of a medication, maybe they just need fluid. That's why they're super tacky. When you slow them down, you're going to try and determine what that wave is. But again, as everything gets closer and closer and faster, these are going to be fast rhythms. That becomes difficult. This is the sawtooth pattern that's present in a flutter. And it should be pretty clear to you that this is sawtooth and not, which isn't pictured here, flutter waves. Fibrillation waves. The sawtooth flutter waves are generally going to happen in a pattern. This is abnormal. It may be slightly irregular, but there's a pattern present, so it's not irregularly irregular. So the sawtooth really only represents, for our purposes, atrial flutter. And then we can have some wavy waves in here that merge. So this is probably a little bit of a P wave. These could be non-conducted P waves. Your T wave is slightly depressed, and maybe some depression here for the ST segment. And then we have another, this might actually be a P wave. So when we're looking at rhythms where the ventricles are not getting the entire story, the ventricles are blocked by the AV node from receiving the signal, we can end up with P waves happening all over the place. And that's really difficult, because if that's happening because we have like a wandering atrial pacemaker, that's one thing, but we could also have a non-conducted PAC, which is a different thing. And the only way you know it's non-conducted is because there's a P wave, no QRS. But sometimes the pacemaker doesn't tell the AV node to depolarize, so there's no QRS. That's where these things kind of blur together. The nice thing is they're generally not going to change your treatment in that presentation. All right. So a couple of rhythms to talk about today. So wandering atrial pacemaker, that's the first. Again, generally not going to be a emergent rhythm. So with the exception of what we'll talk about on Wednesday, SBT, some atrial tach, depending on its rate, and a flutter and a fib, with the exception of those, most of these are be findings that are abnormal, but probably not impacting your care. They're probably the result of whatever's impacting your patient, or they're normal findings for that patient. All right, so with wandering atrial pacemaker, there's also another term. So this is WAP, right? We could call it WAP. It has another name in the Huff book and in the paramedic textbook. Multifocal atrial pacemaker. Okay, so really, I think multifocal is a little better in the sense that one of the things that tells you that this is not good, is not normal, is that the P waves are going to look different because they're coming from different areas, right? Now, the SA node depolarizes and should give us that nice clean waveform, a rounded upright P wave in lead 2 view. But if the atria has another area, we'll call it an ectopic focus, meaning it's a beat originating from outside the place it's supposed to be, just like ectopic pregnancy is pregnancy outside where pregnancy should occur. So you can have an ectopic beat that looks like a P wave, but it should look different than your SA node originated P wave, if that's present. So keep in mind, the SA node should result in, most cases, an upright, smooth, rounded P wave. Okay. So the key here for both wandering atrial pacemaker and multifocal atrial pacemaker is that you have 3 or more abnormal P waves. They are different morphologies. They don't look the same. If it's 2, then it wouldn't qualify if it's 2 different morphologies. Could be that they're leading to this, but it wouldn't qualify here. So it's three or more of these P waves. All right, let's see. Let's look at a better example. Now, because these are coming from different areas, they can sometimes result in perfusing QRSs. And if they're coming from different areas, they may not be coming in the same timing. And if they're at different timings, resulting in different ventricular depolarizations, this would be irregular. But it likely has some type of pattern. Now, again, make sure I mentioned this before, you have to diagnose the underlying rhythm in all of these cases. So if you had a PAC, which we'll see a little bit later in the rhythms, you still have to diagnose the underlying rhythm that has a PAC or a PJC. That's just an extra part of describing your rhythm. So we're going to try to seek to identify these. Why is this not a sinus rhythm? There's kind of P waves here. They're different forms. So it's not all coming from the sinus node. So this wouldn't qualify as a sinus rhythm, even though it has P waves. So let's say, let's start with this one. This one looks maybe the most regular, but it has an add slope. Let's start with this one. This is the kind of most regular. And we'll talk about what this is. This is not a normal QRS presentation. This is, I'm assuming, in lead 2, because they didn't say otherwise. But this is going to be a presentation we'll talk about a little bit later. So disregard the QRS as abnormal presentation for a moment and focus on the P wave. So we have a P, a PR interval, a QRS, or really an RS wave. Actually, this is an R subprime R. T wave. T wave is bigger than the P wave. And sometimes it can be hard to tell the difference between. Sometimes they land on each other. So it really takes looking at. P wave here, what's wrong with it? Inverted. So what does that might tell you if this is lead 2? Coming from the AV, the junction close to the AV, moving the opposite direction. But it still did result in depolarizing. So the AV node didn't cut this one out. And then we have here, looks like this is the P wave and another P wave is stacked upon it. I think this is artifact. Very small T wave, peaked P wave, QRS, T wave with the P wave on top. This P wave, or this, we'll call it an abnormal P wave. This abnormal P wave doesn't really look like any of the others still. So we have at least 1, 2, that one might have been the same, but we had a second one on top of it. So that'd be 3. Peaked, maybe that was peaked, so 3 or 4. This looks different than this, 5. This looks different from all of them, and it has a weird slope. That might be the intersection of a T wave. Peaked, so this is similar to this. So we can see we have at least 3 morphologies in that presentation. Let's see, we got this, T wave. This almost looked like it would have been biphasic, T wave, peaked, T and P together. And the regularity of this, as you probably can tell just pattern recognition, is irregular. So this is wandering atrial pacemaker or multifocal atrial pacemaker. If this is present at a rate that's between the normal range of 60 to 100, then it just has that name. But if it's faster, and it can sometimes be faster, it's usually slower. If it's faster, then we may give it multifocal atrial tachycardia as a name, MAT. So let's say this is 60 to 100. And then if this is what results and it's greater than 100, multifocal atrial tachycardia. So it'd be fast with multiple areas. So let's go through our steps of rhythm recognition and use a couple of our tricks, because one of the things that ends up throwing us off a little bit, especially with non-perfusing P waves or non-perfusing PACs, is the regularity may not be obviously irregular. So here it kind of doesn't matter. This 6-second strip. Doesn't really matter where we start when we're doing our measurements. I would try to find a complex, a beat, a single beat that looks the most normal, or that repeats the most if there's not one that looks pretty normal. This one looks the most normal to me. Not as peaked, doesn't seem to be a TP wave, results in a T wave, has a QRS. So that's the one I'm going to perform my primary measurements on. But again, in the Huff book, it doesn't know what you're picking, so you might get a range. All right, so what's our rate here of QRSs? We'll assume the QRSs are perfusing. 140. Yeah, I think it's probably 142. Yep, great. So tachycardia, so that would be wandering atrial pacemaker, underlying, but since it's fast, it's multiform atrial tachycardia. Okay, still got our steps up here. Could we use the sequence method on this one? No, it's pretty irregular. Is there an upright P wave? Well, there are upright P waves, but they're not necessarily sinus waves. So that tells us it's not sinus in origin, or at least not all of them are, because some of them could be coming from the sinoatrial node, but it's not sinus in nature, so we can't call it that. So it's not sinus. So that's the first clue that this is abnormal if we're going through the steps. Is this rhythm regular? So I want to caution you when you're doing the measurements and when you're using the box of pain, which you'll be using right after you finish this mini lab that you had. You'll use the box of pain to start preparing for statics and dynamics. When you're looking at actual rhythm, sure, get a quick look, see if it's irregular, but you need to march out to R to R. Because when you have non-perfusing PACs, when you have some of these abnormal rates, it may not be very clear that something is premature versus something that's just irregular until you start measuring it out. So let's do our R to R. You can say, well, I'm not using the screen now. Okay, so let's assume that's my most, I'm going to use this for my measurements. Let's assume this will be my most normal orientation because we had enough time for the T wave. There's enough space for the P wave, even though it's abnormal. So this is kind of, I'm going to assume what my underlying rate would be if the SA node was working. Okay. This looks like this. Aside from the P wave changes, the QRSs look the same. A little different in amplitude, but this is happening out of sync, so that's irregular. Also not in sync. And this doesn't have any PACs in it just yet. We'll add that in the mix, but it's just irregular. None of them really line up. But there is a pattern. And the pattern is not in the QRSs necessarily. The pattern is my P waves are changing. So this is irregular, but not irregularly irregular. Irregularly irregular will have no pattern, no discernible P waves, would be AFib. All right, it looks very similar to AFib though, aside from those P waves. All right, so wandering atrial pacemaker has at least how many morphologies of P waves? 3 or more, so 3 counts and greater. If it's greater than 100 beats per minute, then it would be multiformed or multifocal atrial tachycardia. And sometimes this results in slow rates, which would lead us to bradycardia, which we might actually have to manage, depending. All right, here's our PAC. So PACs are ectopic beats. Ectopic beats are used generally for things like PVCs, PACs, and PJCs, but we're going to hear ectopic foci. Ectopic foci means outside of the normal area. An ectopic beat, as a premature atrial contraction here, means that it happens earlier than it should. And sometimes it perfuses. If it doesn't perfuse, then you'll see just a P wave. It might have a different morphology than the underlying rhythm if we had, say, normal sinus rhythm underneath. The P wave may look different, but the QRS should still be narrow if we're talking about a PAC. Because the PAC is not a whole rhythm that's originating from other areas of the heart, but one beat that comes early from another area of the heart. It's probably not coming from the sinoatrial node. So for this one, let's do our steps. What's the rate? Okay. What do we think about our P waves in general?
They're all the same shape.
They look pretty regular. Okay. Let's see our R to R in general. Oh, too long for that. Okay, so remember, premature. It always happens early to qualify. All right. Okay, so ignore this line. That's just where I put my two pieces of paper together. So R to R is good. The beat should have landed here. This is early. Okay. Now, when this started, it reset their depolarization cycle because now it's back in line, right? If it was another PAC, we would expect the regular beat to be here. So the PAC reset their depolarization, and then it went with it the rest of the way, right? Because otherwise, we would have had another beat here. So this is our PAC, and it's perfusing in the sense that you can't tell perfusion from the screen, but it has a QRS, so it could be perfusing. It could be an extra beat. If you felt this, it would be maybe if that's the only one, maybe imperceptible. You might feel very regular with some one variation of one PAC. So usually you can't really tell a PAC as well, and the patient doesn't necessarily notice it unless there's a lot of them. PVCs patients will notice because you have this really big thump from the ventricles that is a little slower than the origination if it came from the SA node. The PACs and PJCs, it may not feel any different to them, especially if it's just one. Okay, so premature atrial contractions generally have a slightly different presentation, but they will have a narrow QRS. They should have a T wave. They can land anywhere, so you could have a PAC that starts here. The challenge, though, is that how this becomes a PAC and whether or not it's perfusing is tied to the idea that we still have to worry about the repolarization of the ventricles in the AV node. So if the PAC happens to occur with its initial P wave, or origination if it's an abnormal P wave, with its original atrial wave that starts this, if that happens too close to where the ventricles or the AV node haven't fully depolarized, so probably in the areas of repolarization, absolute refractory period, then we could get the P wave and it might be stacked on top of another wave, but it won't create a QRS. Generally, the PAC that's not perfusing just happened too early in the cardiac cycle for the cells that were sending it down. The atria, by the time the AV node is starting to repolarize, the atria is already repolarized. So it can start a new beat with no problem, especially an early one. But it's a little early sometimes for it to get transmitted down to the ventricles, and all you would see really is a P wave. This one's visually clearer, right? You can really see it's very early compared. You don't have to march out to R necessarily to see it. And it looks different. And notice where it's occurring. P wave, QRS, a little bit abnormal inversion T wave, P wave, QRS looks the same as this. P wave, QRS. Right at the end of the T wave coming back to baseline, this starts early. So we should have had from here to here. So our beat would have been here. And this P wave doesn't look the same, right? Partly it could be because it's stacked right on top of our, right on top of the end of the T wave. But the rest of it looks pretty similar. The QRS probably measures about the same. The T wave's doing the same thing. So really the ventricles don't really have a change. Whatever's wrong with the ventricles producing this presentation, that hasn't changed. And then notice this little change in morphology. I think that's not a PAC, but let's see. That's one box I would count. A little different morphology, but not enough. There's a PAC. The rest are about right. If this is abnormal, your PAC wouldn't count in the wandering atrial pacemaker count. So this has maybe two different P wave morphologies, not enough to count for that. So this underlying rhythm would likely be a sinus rhythm that has a PAC, and this might be perfusing. Again, we say perfusing if there's a QRS, but that really would have to determine, does it result in a pulse wave? And slightly irregular because of it. Let's see. There we go. So let's look at this one and find it. Let's diagnose the underlying rhythm. So what's our rate? And it gives you a little on the sides. So our 6 seconds is here to here. So we won't have an exact even number of on the 0. Yeah, 68 to 70. All right. Is our do we have P waves? Okay, so this one doesn't really count because I didn't use it in my measurement. So P wave looks about the same. P wave, QRS after each one. Okay. T wave, QRS, missing P wave. P wave, QRS, P wave, QRS, P wave, QRS, P wave, QRS. So you can see, one, it should be pretty visually clear that that's early, right? If we march out to R, this will be early. But the P wave basically here is inverted or coming back at the tail line of the T wave. I'd call it inverted. So that's a underlying sinus rhythm. We said the rate was 70, right? So normal sinus rhythm with a PAC. And it has a QRS, so it could be perfusing. Okay. All the other P waves look normal? Or the same, rather? Yeah. Okay, of course, do your PR interval measurements, but these are the primary patterns that we're trying to measure and pick out. Excuse me. Okay, let me get this cycle. All right. All right, so what's our rate for this rhythm? Same lines, basically. 60. The PAC might have changed the rate a little bit for this picture. So again, a longer rhythm will tell you how often they're happening, all that good stuff. This is just a small picture. P waves here, here. PR at interval would measure normal. Looks like normal P waves. Looks like normal P waves. They all look the same there. Their R to R is like the width of this paper. So from here to here, that's normal. Here to here, normal. Early PAC should have landed here. And didn't land there. So what's happening here is this depolarization occurs pretty normal. This happens early, should have landed here. Happens early. T-wave morphologies change. It's peaked higher. QRS still looks narrow. T-wave looks about a little higher actually than the others, but about the same with our sloped return to baseline. And then instead of having the beat occur where it should have after this started, or where it would have landed because it didn't interfere with depolarization, this created an extra long pause. The patient may feel this a little bit better than they would if it was just a PAC in the middle. So in this process, when it stopped, when it depolarized, part of the process can be that when this happens early, it resets the time of depolarization, repolarization cycle. Because if it's going to the QRSs will have been depolarized. And as a result, the SA node may not fire when it should have, because this came from somewhere other than the SA node. And that results in a pause that's not compensated for. But this would be still our PAC. And with the QRS complex, so maybe perfusing. All right. What's happening here? Do you see a pattern emerging? Erase my lines. That line's right. Bless you. I guess let's see. This isn't a 6-second strip in total. All right, so which is our normal? Does this look like the normal one? It's kind of difficult, right? Because there's not really any normal ones. They're all impacted by this occurring, right? So where are our PACs? Is this a PAC? From this beat here, is that a PAC? No. Except, I don't know what happened here. That's a challenge. That's why you might need it. But for our purpose right now, let's assume that that's what the rhythm's looking like. This PAC, normal, PAC, happening early, normal, PAC, normal, PAC. Okay. So the pattern here is that, and pretty regularly, I won't measure it right now for time, but if we measure those R to Rs, and they're basically stacking up as the premature beats are happening at the same cycle. But if you look at the T waves, they're very close to the same spot, the T wave, that the P wave is starting. One, why couldn't this P wave create a QRS if it landed here? RNT phenomenon. We're still in early repolarization, so that likely would have maybe changed it could change the morphology of the T wave, make it a little bit weird, make it a TP wave, but we wouldn't have a QRS after it. So notice it's happening just after the peak of the T wave, so that's the relative refractory period, so that's a time that we can have another beat signal in. And this is occurring. You can see that the P wave is much different than the others, partly because it's stacked on top of the T wave, but they all look the same when you look at the PACs, right? Those PACs look similar. No changes in their morphology. Okay, so when you're talking about ectopic beats, and this will be PJCs, PVCs as well, we can have multifocal and unifocal. Multifocal means the ectopic beat. Here our purpose is PAC, but PJC, PVC be the same. Multifocal means they're coming from different areas. And because our lead view doesn't change, right? If I put my leads on my patient, from beat to beat, my lead stays in the same spot, aside from maybe wandering on their chest if I put it too close to their chest or whatever. So my view stays the same. The only reason the waves would look different is if they came from a different part of the heart. Because if they came from the same part of the heart, they would all look exactly the same, right? If they all came from the SA node, they'd all look like they came from the SA node, and they wouldn't be early. So these are unifocal, meaning that they all look the same, so you have to check your morphology between them. And then something else is happening here. Anybody know what it is? Yes, but on the PAC specifically. The slur is not it won't really qualify as true ST depression for an MI, but these PACs are happening in a particular pattern. What's the pattern? Every beat we have a PAC, right? So this is how it looks. So let's call this morphology. Okay. Then we can also qualify it by the pattern. If ectopic beats run together, then we call them terms that are pretty, I think, sensical. If we had like a PAC and a similar PAC, or it could look different, but we had a PAC and a PAC happen together, that would be a couple of PACs or couplets. And this is usually terminology we're probably familiar with from ventricular ectopic beats. If we had 3 of them, then we would have triplets. And generally, not for PACs, but when you have PVCs, if you have more than 3, you're starting a run of VTAC. Because as you can imagine, PVCs, as our kind of, I think everyone understands, it has nothing except for a sine wave. There's 3 PVCs. Doesn't that look like VTAC? PVCs, if left untreated, when they get to that phase, turn into VTAC. Runs of VTAC, full VTAC, cardiac arrest. These won't result necessarily in that, but they could change the atria a bit. So here what we're looking at is what's the pattern. And the pattern could be together, like I just mentioned, or it could be skipping beats in a particular way. And if we're skipping beats and they're not running together, together would be couplets, a couple, right? Triplets, and then after that, it's a run of whatever we're looking at. But when we talk about them occurring, skipping beats, the number of beats they skip will tell us whether we have things like bigeminy or trigeminy. Now, these terms, again, will translate to most things, but when you're caring for a patient, we're not generally looking for PACs and worried about them being bigeminal or even couplets of PACs, because the ventricles are still doing what they're supposed to, and they're narrow. The QRS is narrow, so electricity is going through them, so they're pretty healthy. Because if their ventricles were not very healthy, then we'd get a wider QRS. So it's less likely this is going to result in something that's going to go to cardiac arrest than if these were PVCs, but the same terminology will ensue. So those are bigeminal. So another picture. So for this, just look at the pattern. Identify where your PACs are versus your regular beats. Determine what their morphology is. Do they have a different morphology for this box? And then what's their pattern? So I'll call this pattern. Of course, it tells you at the bottom, but look for the view. Can you easily see it from across the room? This on a paper, you probably have to measure R to R to capture the pattern. Okay. Now, this is not called trigeminal PACs. What's the underlying rhythm? Looks like sinus tach with trigeminal PACs. Now, we worry about this because that means that, and what about their morphology? Do they look the same? So they would be unifocal. But we don't, if you don't call it unifocal, you would call it multifocal. Unifocal is just given because they all look the same. So if it was multifocal, I'd say multifocal trigeminal PACs. And again, if different areas of the heart are sending off their own beat, what does that tell you about the heart's environment? Yeah, there's something missing. PACs, PVCs, PJCs happen because of an abnormal concentration of water, abnormal concentration of electrolytes, abnormal concentration of oxygen, abnormal concentration of acid waste, changes in glucose. All of those things change the cardiac environment so that it makes it more irritable. Remember, irritability. The ability of the heart, when it doesn't have what it needs, to just send off a beat, which keeps the person alive in some cases. If irritability didn't exist, then we wouldn't have this occur. The heart would just stop when it didn't have what it needs. So if we see either multifocal, that tells us different areas of the heart are having a problem. And again, it may not be something we have to treat, but it tells us this heart has not just one area that's not getting perfusion for whatever reason, may not be like an MI, may not be a blockage outright, might be the start or a narrowing artery, could be some abnormal tissue, could be something they were prone to or predisposed to because of their life or born that way. So as we start to see these things change, that tells us we have different regions of the heart that are sick, and that's a sicker heart environment than somebody who doesn't have changes in the morphology of their waves. And this will be something we'll look at in a variety of different, these terms will be something we'll look at in a variety of different chapters as we look at our ECGs. Let's see. All right, so I'll leave that there. So this is a 6-second strip. Let's analyze this rhythm. Is this a good rhythm to a good beat to analyze? Why not? Does it look like this? Does it look clean where you can see your measurements? It's stacked on top, right? This one might be what I start my measurement with if I'm doing when you do, not if, but when you do, PR interval, QRS, and all that fun stuff. So you kind of have to get a frame of reference. And usually, for me, I just try to find one that looks the most normal. Sometimes you can't. Okay? So our rate would be 148, just about to get into an area. What do they say? 94 beats per minute. Oh, and then we have our PAT. So the underlying rhythm, because this beat is not a PAC, would be a normal sinus rhythm. The change, though, is that you have this run of, what does it say? How many runs? 7. So then, here's our 6. Does that give us 7? And then this one. Now, a run of PACs, not as concerning, but it makes them tachycardic. And if they're not perfusing well, that can impact their overall care. But if you saw this with PVCs, you'd be very concerned. You'd be preparing your patient, probably giving them an antidiuretic and preparing to cardiovert or preparing for cardiac arrest. In this patient, this beat, if it just happened here, again, need a longer rhythm. If this just happens here, I've got a momentary change in the rate, assuming these are all perfusing. They all have QRSs, so there's a good chance that they are. I might momentarily change cardiac output. Maybe the person gets a little bit dizzy, feels flutter in their chest. But if this doesn't keep happening, then my patient will probably be generally stable. So none of these, as you can tell, none of the ones that we've looked at so far should contribute to a person having abnormal hemodynamics. So what that means is this is because of some problem. This is not the problem we're chasing, okay? And again, all ectopic beats generally have that same thing in common, an abnormal cardiac environment, irritability. So this is not something you're aggressively treating. This is something you're giving oxygen for, starting a line, giving fluids, and they probably need to be evaluated, or if not, maybe they're even on a Holter monitor looking at their ECGs already. Now, down here, this is a problem, okay? This is a big problem for us in the Huff book. This is why this chapter is challenging aside from all the variations. So how would you get the rate of 94? Using the sequence method, getting the sequence method from the normal ones, if it was on the strip you're presented with, hopefully they'll provide it for you. But yeah, a longer strip would be better. And using the sequence method, this is regular, like this is regular. These are regular. So you'd split the sequence method between the two. Do I care if you do that? Well, Huffbook won't give you the right answer if you don't, but I don't necessarily care if you do that, because what I'd want you to do when you see this is I need a longer strip. And let me see if this is just happening now. Is this happening again? It may not just be like to count it. It would be to see how often does that happen, or what were they doing when that happened. Have them on the ECG running a strip when you move them to the gurney. Does standing up make this happen? If standing up makes this happen, what's your problem? Yeah, you just did orthostatic vital signs. You just did it with an ECG. When somebody's heart rate changes greater than 10 beats per minute, or their blood pressure changes greater than 10 millimeters of mercury per minute between seated position, it's a positive orthostatic finding, which means they're hypovolemic. They need fluid, which would be a great explanation for any ectopic beat, right? Because if you don't have fluid, you're also assuming that they have enough to perfuse. If they don't have fluid, they don't have electrolytes. If they're not perfusing well because their fluid's down, especially as they make a transition from one to the next, then they are also getting oxygen to the heart in that same range. So oxygen, IV fluid, that probably changes this rhythm. Unless there's some other thing like drugs or some other thing that you're looking through. So again, not the problem, the symptom of a problem. So when we don't have a cardiac rhythm, that's the problem. What do we do for treatment? We investigate cause, which is what, not really an acronym, but abbreviation. H's and T's, right? Hypovolemia, a variety of things, obviously, but this is probably, especially if this is positional, hypovolemia. All right. Okay, imagine you're an EMT basic, and the medic hands you this strip and says, "What's up? Is this bad?" You could jump to some conclusions if you don't have the background knowledge, right? So this is where you stop, wait for a second, think about it. Again, you're not talking out loud, perhaps. This is all going on in your head. You'll do it very rapidly. So it looks to everybody else like you're just looking at the pattern and you've got it. You're like a wizard or a magician. You're analyzing it internally. You're just going to be very rapid at it. So again, you'll do all your measurements. I'm just looking for these abnormal beats. All right, let's see. Good stuff. Let's see. Common as a result of increased automaticity of atrial pacemaker cells, which could be near or at the SA node. It's just not a specific one cell that's generating the beat. Because remember, usually the atrial pacemaker cells, they go off of the strongest and fastest signal that a beat generates in the SA node. Let's see. Triggered activity or reentry mechanism. This is a particular term that we're going to actually see in AFib, A-flutter, like when it's really more meaningful, and in SVTs. And what this means is, instead of having, for the reentry mechanism, instead of having a nice clean separation between atria and ventricles, where we know because of the atrioventricular tissue, where our valves between the atria and the ventricle are made up of, are connective tissue, they don't conduct electricity, right? Normal heart. The only way to get electricity from the atria to the ventricle should be through the AV node, which is going to hold on to the beat for a little bit to slow it down for atrial kick, and then let the ventricles have their signal. When there's re-entry, it means that there's another pathway that goes through the atria and into the ventricles. And usually this is cyclic in the sense that if we had our heart here, AV node, bundle, all that fun stuff. SA node, Bachman's, intranodal, right? If we have a reentry phenomenon, then there's some place in the heart that has a little bit of space that has depolarizing muscle, myocardial cells in it. And when the signal reaches that, it doesn't get blocked because it's not AV cells. They're just likely atrial cells or ventricular cells. They send the signal back, and then it becomes, excuse me, reentry phenomenon. Man, thank you. There'll be a lot of that today. I guess Benadryl's not working yet. I'm still awake though, so I guess that's a part. So this sends a signal that goes into the atria, from the atria into the ventricles, and usually will stimulate the ventricles to depolarize to some degree, or at least send the signal back up into the atria, which might cause another additional depolarization. So again, this is most concerning when it leads to a consistently faster and faster rate, and that's what we'll talk about with SVT. But AFib and AFlutter can have some of this, and that's treated, not in our setting, but that's treated in the hospital by having cardiothoracic surgery. Well, they'll place, not generally open heart, but they'll put in a lead into that space once they identify it, and they'll burn it, which is called ablation when you do it in the heart tissue. Turns it into scar tissue. Scar tissue lacks those characteristics of myocardium. So basically, they just made, it's not necessarily the same connective tissue, but they just made it as if it was normal. Sometimes, though, they have multiple of these as well. So we'll talk about what those reentry pathways are when we get to SVT. All right, increased sympathetic tone, of course, especially if it's getting tachycardic, but that comes from things like this, especially if the patient's somewhat dehydrated. This, even if they are hydrated, some neurological conditions, and then some things wrong with their endocrine system as our mediator of sending signals between the nervous system and the cardiac system. So again, need to recognize them, need to differentiate, but probably not having a major impact on your care aside from investigate the underlying causes. All right, let's look at this one. I'll leave that there. All right, so with this rhythm, we have some different morphologies of our QRSs. Let's see, so we're from here. So this one gets kind of split in half. So almost all 1, 2, 6, so like 62 or so. I'd probably do my measurement off of this here. Choose this R/R. Should have landed here. Should have been another one here. Okay, and these are off. So maybe look at these. Sequence method wouldn't work here. It's too irregular. Okay, note the different morphologies. So we do have some rhythms that are sinus. It looks like through this route, again, we have some different presentations, but through this route, we have mostly the underlying regular rate. I don't know what happened there, so maybe this is a little off, but these two seem to be pretty close, so I think I'd call those my normal rate. And then we had a big pause, right? So it's from here to here, and then this beat originates. And you can clearly see there's a difference in this P wave from the others. This is almost biphasic. It has this little piece, but there's a lot of artifact on here because look, there's nothing happen electrically in the heart right here. This is flat line, for lack of better terms. This is the isoelectric line, and look how junky it is, right? And it's not probably something that you would have a lot of control over in that. Maybe it's probably not a loose lead. We'll look at different artifacts in a little bit. But this artifact here is impacting all of our other beats. So that's kind of what this is occurring on. So I'd assume that might be a pretty normal P wave underneath of it. This is peaked P wave, results in a beat, and was a long pause. So remember, this is going to be the use of automaticity. What we were talking about with the rest of our premature contractions was that when the heart has an abnormal environment, it just sends off a beat. And those beats, if they happen early, are premature. But if nothing happens, if say our heart is going along fine, I don't think that's what's happening here, but assume it's going along just fine, depolarizing, and then the SA node doesn't send a signal. Well, the cells are always waiting for a signal, and they I would imagine, are able to sense that there's a longer pause between, because they're able to send off extra beats. They can sense a longer pause in which the signal didn't come when expected. Now, it doesn't always happen that the AV node, whatever beat pacemaker cell is going to back it up, doesn't always land where it should. It waits a little longer. So in some cases, you have a sinus pause underlying. There's no sinus activity here. And as a result, we have another beat that comes out of it. Now, this isn't a PAC because it's not premature, right? Our other beat should have landed here. So premature would have been in this area. So it's not that. This is called an atrial escape beat. And the atrial escape beat is telling you that for some reason there was too long of a pause, and automaticity caused another atrial cell to depolarize. And that other atrial cell hopefully started another QRS. In this case, that likely would be perfusing. So that's an atrial escape beat. The big difference in identifying these, though, would be an atrial escape beat happens after the premature phase. So it should happen after the R to R interval that you were expecting the next beat to land on. And escaping means it threw out a beat because nothing was happening. In this case, a pause. That can change the rate. So remember last week we looked at sinus pause and sinus arrest. Sinus arrest can pause so long or stop the heart for so long that we have a rate suppression where when the beat comes back, it could be slower. Rate suppression meaning slower. So that still happens here. The thing that's different is that this beat is an escape beat. So you see why you have to measure your R to R. Because if you don't measure your R to R, you just make a guess. Oh, that's a little out of the ordinary. That's premature. That's clearly not premature, hopefully from even just the pattern. But if you call it the wrong thing, you won't be diagnosing the rhythm. Now, again, there's an underlying rhythm here, sinus rhythm, right? We have a sinus pause, and then that's just an extra beat. Still, I would consider it an ectopic beat. It's just not premature. It's coming from somewhere else. And how do you know? That T wave doesn't look really anything like these. It's a lot taller. The QRS is pretty similar to these. I'm not sure why this QRS amplitude is off. I'd have to see a bit more of the rhythm off the top of my head, unless it tells us because they know everything apparently. All right, here's where it gets really tricky later. Right now, maybe not as tricky because you're just doing atrial rhythms when you do the Huff book for this chapter. But once we start putting all the other rhythms together, this becomes an issue for us. Okay, so these all look pretty similar, right? Even this, aside from that, those look pretty similar. Let's count it out. So from here, 1, 2, 3, 4, 5. So this rate's around 50, a little more than 50 because we got a chunk of this on here. So a little more than 50. So maybe a bit bradycardic. This is your regular because we'll talk about that in just a second. But look at this long pause between, and we can measure it. I know I didn't count this one, so let me start here, and I'll go backwards. Do you see how I find one in my count, and then if there's another one I need to confirm, just go backwards. I wouldn't start here, though, because you don't know what happened before that. So here and here, so that's our R to R interval. That looks regular. Ooh, really close. That's pretty dang close. Yeah, I think for my purposes on this screen, I would say these are meeting the R to R interval, and we have a missed beat in this area. Okay, so P wave, T wave, P wave, T wave, P wave, P wave, T wave, T wave, P wave, T wave, P wave, T wave. This little blip here, and we'll talk about an Osborn wave, which is a small wave that follows the T wave, but it only really happens when patients are hypothermic. So assuming this patient isn't hypothermic and it doesn't look like a P wave, we'll look at them later. This looks like some of these P waves, right? It looks a lot like this one. These are a little bit more rounded. Okay, so maybe similar with uh, a single separate morphology, but this is a P wave that occurred before the AV node and the QRS was ready to deploy it. So it didn't result in a QRS. So a P wave that just happens to show up prematurely is an indication that you had a PAC that wasn't conducted. So that's a non-conducted PAC. The underlying rhythm would still be sinus. Do we say the rate was slow? So sinus Brady, unless they had a different number. But a sinus rhythm. This is a non-conducted PAC, and we don't call this a pause in the sense that it's not a pause like a sinus pause or a sinus arrest, because the SA node was doing what it was supposed to. But when this beat came, it reset all of our depolarization cycles, so there wasn't a conduction, and another beat didn't happen right after it. But after the pause here from, again, not sinus pause, but after the pause because of non-conductive PAC, I would say these come back on track. They're close enough that I would count them, because you have one small box of variance on either side, and they're okay. And they happened exactly where they were supposed to. The only thing making this irregular is that PAC wasn't conducted. If it was conducted, it'd be irregular, but it'd be clearly a PAC because it'd be very, very early. So non-conducted PAC. So again, this is really difficult if you have multiple non-conducted PACs, even if they have similar morphology with that P wave, when you start looking at things like sinoatrial blocks, because sometimes it's hard to tell, is that part of the block or is that a PAC? Because they could have both happening underlying. So keep an eye out for that in the next couple chapters. But for right now, if you see an aberrant P wave with nothing after it, it usually results in this pause, then it's probably a non-conductive PAC. Okay, fun stuff. Again, probably still not clinically significant, probably not the thing that you're treating, so don't get carried away. Just investigate why it is. Is it a problem? Is it contributing? And maybe it's not. Maybe they're perfusing fine. H's and T's tell you everything's fine. This is just them. Maybe they need a further investigation at the hospital, or they know they have these. I don't know if you've ever had a PAC or PVC or PJC, but your heart stops momentarily if you have a pause and you can feel it. I've had PVCs. I have no idea about PACs. Let's see. This one sucks. Okay, so underlying rhythm, just quick glance. These all look about the same. Looks pretty regular. Pause here. Could be easy for you to consider this one of our sinoatrial blocks or pauses. The only thing that tells you there's a PAC that's non-conducted here is that it landed basically right on top of the T wave and changed the T wave's morphology. Right? See, pretty rounded, peaked, round, round. That's hard to pick up on. Very hard to pick up on. So it would be easy to call this maybe one of our sinus blocks, which can, again, be underlying rhythms here because we just did sinus, so everything can move forward. So there could be underlying sinus blocks or pauses here. I'd have to march on my R. But the P wave landed right there, and it was so early, nothing got conducted because, again, that's just when we started crossing over at about, let's see, the curve is about a box wide, so it's just after the peak of the T wave, so it's not RNT phenomenon, but it landed right at that point. And so it's not ready to conduct, it's not ready to depolarize, it's still repolarizing, so you get a P wave, it's buried in that T wave together, creating a TP phenomenon, and that's a non-conductive PAC, a challenge. So I wouldn't hold it against yourself if some of these you're like, oh, it's that? When you look at the back. But because that happened, it reset the atrial depolarization because it was a P wave that happened. So the atrial center had to repolarize before it could send the next beat. So you get a delay in that conduction. It's not conducted. TP. Here's some subtle T wave changes. So, and notice though, because it reset the cycle, you get a bit of a pause afterwards. So a little bit of a clue that if there's a change in the T wave, and usually it's that they happen together, so the T wave is usually larger than the others, but it could just be a change in the contour, as it says. And as a result, nothing happens after that. And this chapter is probably going to be a non-conductive PAC. All right. Let's talk about atrial attack real quick, and then we'll take a break. Okay, so multifocal atrial attack is not the same as this atrial attack, okay? Multifocal atrial tach was an extension of wandering atrial pacemaker, which is what we'll probably call it. I believe your paramedic textbook calls it wandering atrial pacemaker. The Huff book, or the other way around, the Huff book will call it multifocal atrial pacemaker. That's only the term you use if you have more than 3 different P-wave morphologies in a strip, and the rate is normal, between 60 to 100. If the rate is above 100, but we have more than 3 or more different P-wave morphologies, that's multifocal atrial tachycardia. Atrial tachycardia just means that you have a tachycardia originating in the atria, just verbally. Let's count this rate and see if that makes sense as to why this looks to have missing waves. Yeah, almost 200. Yep. So that's a problem, right? If you have a rate close to 200, and those are QRSs, right? You can see the QRSs. That's a ventricular rate that's originating from the SA node. The QRS is still pretty narrow, so if we measure it out, it should be less than 0.1. As we get that fast, hard to see in between, hence these positions, but also likely to cause abnormal perfusion, especially if they're already hypovolemic. So again, you're making a deduction here. I haven't read all this stuff up here, so maybe there's a little bit nuance in there that'll help us. But generally, when you're looking at this, if this QRS is narrow and pretty regular, then I would assume that the reason this T wave looks so high compared to what you would expect for this QRS, it's not abnormally high, but is that your P wave is buried inside of it. And so the TP waveform is what you're kind of looking for, from what I recall, in atrial tachycardias. Now, this is more likely, still not like it will always produce hemodynamic instability, but of the things we've talked about so far, because this can go fast, this is likely to cause some change in the patient's hemodynamics. Maybe you don't have to manage it, but again, this fast decreases stroke volume. Decreasing stroke volume decreases all the other effects that cause cardiac output to go up. All right. So atrial tach, not the same as multifocal or multiformed atrial tach. Yep, some atrial tach. The PAT, the P here, paroxysmal. So this is a tough term because we still use it, but in old terminology for SVTs, we used to call SVT, just another version of SVT would PSVT. That was the only 2 versions of SVT. Now we have 5 that we'll have to memorize. The P in this, or PSVT, the paroxysmal, means that you're seeing it change in front of you, right? So SVT would just be a fast rate that comes from the atria. So there's some other components to it, but it's a narrow QRS. If you have a strip that you printed and you see it change, like they go into SVT or they go into this atrial tachycardia, that's paroxysmal. Okay, the changing in rhythms in front of you is paroxysmal. So that's what makes this PAT versus just atrial tachycardia, because you captured the change. The one above was just straight atrial tachycardia. There was no change, so you couldn't call it paroxysmal. That's kind of the only difference, right? Let's see, where else do we use paroxysmal? Well, that'd be paradoxical. Not many other places, I think, in our terminology we use that. Use paradoxical, which often means opposite, right? Paradoxical chest movement and flail segment. Paroxysmal just means that you see the change. And then you also see it going back into the rhythm here. So you saw like just a run of this beat. All right, let's see. Let's go. We'll talk about adenosine more when we do SVT. I'll give some cautions on SVT and the use of these drugs, but this is showing the steps of converting a patient from paroxysmal atrial tachycardia using adenosine. So here's their atrial tach, given adenosine. Now they have a return after getting the adenosine. Okay, but more on adenosine a little bit later. All right, let's see. I want to get to AFib and aflutter for now. Let's just start with atrial flutter, and then I think maybe we'll see where we're at. Just test your brain a little bit. How are we doing so far? Does it make sense? Practice is what makes this work. You just got to practice a lot in the Huff book. So again, all of them have an underlying rhythm. So make sure you name the underlying rhythm. Try to figure that out. and then talk about the abnormal presentations you find, and do all of your measurements. I'm only showing some of the presentations that have abnormal beats. I assume you can do all of your measurements, because the measurements will tell you whether it's regular, tell you, again, you're probably not finding ventricular rhythms here, so they'll, again, be repeated over and over again. All right. So atrial flutter, atrial fib, and SVT, or the 5 types of SVT, these 3 major categories are where we actually treat tachycardias. Sinus tach, unlikely that it's the cause of the problem unless it's really fast and something else is causing that to happen, which is sinus tach. So generally you don't treat the sinus tach. You'll find the H's and T's for it. Fluid does a whole lot for sinus tach. In any case, even if you're not sure if they're dehydrated, they live in New Mexico. They're probably dehydrated. So give them a fluid challenge. Fluid challenges fix sinus tach. These, though, are not the same, right? Because let's say you have a patient that's in shock. We're talking mostly medical, but patients' heart rates change because of shock. If the patient's in shock, hypovolemic, hemorrhagic, their blood pressure goes down, what do you expect the heart rate to do? It goes up. So sinus tach often is a presentation that giving fluid in most cases. If they're septic and they have sinus tach, give them some fluid. So fluid really does help a lot of this. But again, those are abnormal neural controls, right? If you have a patient that's in shock and the stroke volume goes down, the body sends norepinephrine signals to increase the patient's heart rate, specifically in the SA node and the atria, because the ventricles don't get the opposing signal. And as a result, the heart rate goes up. So if you fix the underlying problem that caused the hormonal release after time, that will be mitigated and it'll go down. But these are abnormal hearts. These aren't hearts that are responding to an environment. Now, whether they're stable, unstable, that can be because of some other component if they already have this existing. But this is, especially if it's new onset, these are the things that we generally have to manage when presenting a patient. So let me hide the projector here for a second, and then I'm gonna write some terms down. I'll give you a stretch break, and we'll go from there. I don't think. Oh, cool! This projector works like it's supposed to. All right. Okay, so AFib, a flutter. Okay. There's rhythm terminology. And then there's going to be patient's presentation. Okay. We'll get to this a little bit later. I don't know if we'll do it today, but this is the second stage because we're going to use specific terms to describe the rhythm that may or may not have an actual impact on the patient's presentation. Because again, remember, electricity, this is the electrical component, is not the same as mechanical. Their symptoms are the result of their heart's mechanics, right? If they're unstable, it's because they're not perfusing. That's a mechanical problem. It could come from the electricity, but you're going to use specific terms, especially in the Huff book, that focus on the electricity. You'll have to determine after that what their presentation is in our guidelines, and that's how you treat them, okay? And again, not all these are going to be things that you have to treat. All right, so let's see. These terms will actually be the same too. So stable means that they don't have any underlying presentation from that rhythm. Means that their LOC is still intact, but their perfusion is going down and probably impacting the heart. It means their LOC has been impacted, they're hemodynamically unstable. Both of these come with hypotension, okay? Now, when I write these terms down for these rhythms electrically, it does not mean that they cause any of these things, okay? It is common that in some cases, some will line up with these, but again, split the difference. And all you're doing in the Huff book is electrical anyways, right? So AFib versus aflutter, we can have things like uncontrolled. This is generally by rate, and RVR, okay? And those are used in the guidelines, but that's still only just recognizing the rhythm. You could have RVR and the patient not be unstable. But if the patient's unstable from them, they're probably an RVR, okay? So you don't always just treat RVR. You treat the patient that has these problems with one of these conditions. Make sense? Keep that in mind because that's the only way you're going to put this together for lab in the field, okay? All right, let's take a stretch break and then we'll go through AFib and maybe just aflutter, just aflutter. Okay, let me just add to these terms because I'm going to put the screen up again. So just make sure when you take notes, you add these.
But it really depends. There are some dogs there who are like, have you done any before? No, that's why I'm a CA. Well, then I don't trust you doing it, which is fair. What is their call? Yeah, I got two. So it really depends on the dog that you have, and some days are slow, some days
All right. So again, putting these in the right spot electrically for AFib and A-flutter. If AFib and A-flutter are used just as those terms, that means the rate's less than 100. We don't really call these tachycardia in the sense of like atrial fib tachycardia, because it's likely that they will be tachycardia. Like that's the normal form. AFib and A-flutter by themselves have parameters that will help us identify them. But if their rate, and you're measuring the QRSs for this, if their ventricular rate is below 100, then it's essentially just these terms. If your ventricular rate, as noted by your QRSs, is between 100 but less than 150 beats per minute, then that's called uncontrolled. That means that this is not being controlled for either one of them, AFib or A-flutter, although we'll just talk about flutter today. The control here that I'll describe is the AV node still, okay? I'll get into that in a second. Just make sure you have these terms down, because when you look at the cardiac treatment guidelines, it uses these terms and it uses the presentation terms, and they're different. So it is possible that a person with a rapid ventricular rate, okay, greater than 150 beats per minute, is going to not perfuse well enough because their stroke volume will go down because they're above 150 beats per minute. That's like our magic number for tachycardias. You can see it all over the place. It's also possible, though, that if their rate is between 100 and 150, for that particular patient, they're so sensitive to that rate change that they could be at 130 and have symptoms that are unstable. Okay, so they're not connected. You have to assess your patient to determine these things. So we don't necessarily treat these because of these numbers. We treat still because of this, but we call it what it is based on these numbers. Okay. All right. Let's talk about fib and flutter. Some questions were asked over the quick break. What's the difference between atrial tach and sinus tach? Atrial tach versus sinus tach. With sinus tach, you generally would still have a P wave, and it's happening, but it's getting buried because if the rate is fast enough, it's getting squeezed together. But it's not getting buried and happening directly on top of the T wave. With atrial tachycardia, you'll find T wave morphology changes, no P wave, unless like it's just slow enough that they line up and show you that little extra bump. But you can see a TP phenomenon where your T wave looks abnormally high. Generally, unless there's an abnormal beat, atrial tachycardias will probably be regular. Okay. And again, we have to separate these from SVT that we'll talk about on Wednesday as well. SVT is usually regular as well. But when you have atrial tachycardia, the P wave is occurring somewhere else, or the P wave, the ectopic beat is coming from somewhere other than the SA node most likely. So the P wave isn't going to line up exactly with the T wave because it's a different beat location. If it's sinus tach, even if it's fast, when they merge together, it's still coming from the sinoatrial node. So they're just going to get buried under the T wave. They're not occurring in an abnormal cycle. So that's one of the differentiating factors. If a patient has sinus tachycardia that's really fast, it can look like any of these because everything merges together. So hence, fluid challenges are a paramedic's really good way to see if we can change things. Because if we give a fluid challenge and it slows down and we can see it's a sinus rhythm, that was sinus tach. And their problem was they needed some fluid. If it's atrial tachycardia, it may not be that simple. It could be some other problem that we're not going to address with fluids. But if you give them a fluid challenge, they might get better perfusion, but the rate may not change, right? So sinus tach from shock, for example, versus atrial tachycardia. Sinus tach is because of the neurohormonal environment in the body saying jack up the heart rate. Atrial tach is because of abnormal centers that are releasing the beat. And if it's irregular and has atrial tach, then it's because it has PACs in it somewhere, causing irregularity. All right. But again, we often don't treat atrial tachycardia. And in most cases, just to be fair, I've never heard a medic say this is atrial tachycardia, to be honest. Like, we're probably identifying something else. All right. So but a very good question. And we're going to have to consider the same thing between SVTs and these beats as well. All right. Now, with atrial flutter and atrial fibrillation, so we got these terms. Let me just kind of make some room for our slide. We're going to define how these are working. So we're going to start with flutter. I like to start with fib, but the Huff book goes in flutter order, so we'll start with flutter. So in the presentations of atrial fib and atrial flutter, there's a lot of similarities between them in their origination, but they're clearly different rhythms on the monitor. Okay, very clearly different rhythms. In your reading, you'll find that they're going to describe that atrial flutter and atrial fibrillation have abnormally super fast atrial rates. And if their AV node is doing its job as a gatekeeper, it only lets some of those rates through to the ventricles, which is good, right? Because as you'll read, if you have fib or flutter, you can have atrial rates 400 plus beats per minute. And if every one of those made it to a QRS, you would have 400 QRSs per minute. That wouldn't be sustainable. That would just be a heart just kind of flailing around, not pumping anything out. They'd be in cardiac arrest, likely. So what's happening here, so this is flutter. Fib is more irregular. Flutter can be somewhat irregular, but it has a more regular pattern. These are flutter waves. They look like sawtooth waves. And because they are not P waves, they're not sinus. So the way that I would kind of put these two things together is first to think about VTAC and VFib, because you learn those at the basic level. VTAC is when the ventricles, again, this isn't just an example of how these two pathologies occur. VTAC, the ventricles are squeezing together, but that's the place that everything is originating. The ventricles are squeezing together because they're not getting any signal from the rest of the heart. They have their Purkinje fibers doing their job, but it's tachycardic. It's a fast rate. It's all ventricular, okay? If you have VTAC, is VTAC always pulseless? No, VTAC can have a pulse or not have a pulse. VFib, you have not the same exact idea, but similar. In VFib, instead of having the cells beat together, which creates a QRS that looks pretty regular for VTAC and can perfuse in some cases, you have not just cells working together in the absence of what they need. It's an irritable rhythm. Now you have all the cells sending off beats, and they're not coordinated. So with ventricular fibrillation, the ventricle just jiggles, right? We're not going to squeeze and get blood out. VFib never has a pulse, right? So very similar in the sense here, except this is happening at the top of the heart. This is atrial. So in atrial flutter, it's irregularly fast, and there's an abnormal orientation for this, which might be related to something in their H's and T's to cause this. But they might also live with this rhythm as well. But with atrial flutter, it still squeezes enough to give us an atrial kick. It's just happening so fast that some of those aren't making their way to the ventricles because of the gatekeeper. Atrial fib, the atria just do this, and you have no atrial kick whatsoever. Okay, that's a major difference between their pathophysiologies. With flutter, you get specific flutter waves, and flutter waves look like this sawtooth pattern. They happen in a ratio to the QRSs. Okay, so let's just count our 6-second flutter waves, and you don't necessarily need to do this in all cases, but let's see what our atrial rate is. Okay, so if it starts here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So that's like almost 300, right? Because that's 3 seconds times 2 would be 6 seconds. So that's almost 300 beats per minute in the atria. What's our ventricular rate? 68 maybe? 68 beats per minute. Their ventricles and their pulse will be 68 beats per minute, but their atria is squeezing much greater than that. So all the flutter waves are happening behind the QRSs too. So sometimes flutter waves line up in a weird way where you don't see one because it's buried by the QRS. Because again, these are atrial. The QRS will always overcome them. These are pretty clean though. It's a nice example. So in this, you do want to try and get a feeling for, even if you're not counting out how many flutter waves there are, like I just did, you want to get an idea for the ratio, right? So how many flutter waves do we have per QRS here? 4 to 1. 4 flutter waves to 1 QRS. So that means, I really like Kathy's terminology in her video, that means that the AV node is receiving all these signals and says, no, 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 yes, you can go through, no, 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 yes, no, 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 yes, no, 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 yes, and that's what's determining your ventricular rate. So the AV node functioning here is what's helping us. And the AV node would like to slow this down to a perfusing rate. That's part of its job. If we have extra beats that are going too fast, it would try to slow it down to a normal rate. Doesn't always work. So our AV node is doing a good job of keeping this rapid atrial rhythm from becoming a rapid ventricular rhythm, okay? So with this ventricular rate, using the terminologies I just used, This is a flutter. That's the underlying rhythm. There's nothing sinus about this. There's no P waves buried in there. This is all just the abnormal conduction of the atria. So this is atrial flutter. You could call 4-to-1 ratio. I mean, in the pre-hospital setting, I don't know that you'd get dinged if you didn't have the ratio. I will on your internship, but your QA manager probably won't necessarily care. What really matters is this rate here. So this is atrial fibrillation, no sinus part to it. It's in the normal range of ventricular rate, right? Because it's less than 100. So this is just a flutter with a 4-to-1 ratio if you went that far, okay? If this had let's say the ventricular rate's the same, we said almost 300, right? Or sorry, the atrial rate's the same, almost 300. And we resulted in 105 QRSs in a minute. That would be a flutter uncontrolled. If this was a ventricular rate above 150, let's say it's 151, 150 would count, then that would be rapid ventricular rate. So the RVR, that's where your cardiac guidelines has you do the most aggressive treatment. RVR, rapid ventricular rate, is important because perfusion really, aside from the atrial kick, only comes from the ventricles, right? Like if you feel a pulse, the ventricles had to generate that. The atria will not generate a pulse that'll go to the place that you can feel. So rapid ventricular rate is directly telling you that the rate is so fast that it'll decrease stroke volume in most patients. Hence the likelihood that with RVR, they might be hypotensive. So let me make this really, really clear, and I'll say it with AFib, and we'll have to remind you in lab 2. But if you have RVR and the patient is generally stable or symptomatic, you're not juicing them. Just because they have RVR doesn't mean that they can't handle it, okay? They have to have RVR, or they could have uncontrolled. They have to have instability for us to get aggressive with it, okay? Make it very clear. Don't memorize RVR, I treat. RVR is just the rate. Memorize, I treat symptomatic and unstable, okay? But again, if you don't kind of have that heads up, it's not necessarily clear in the treatment guidelines. I've never done this, but yeah, I have no idea. This is our cardiology class. Are you here for lab? Yeah, that'll be at what's your lab time? 12? That'll be at 12. If you're are you an actor? This will be the room at about 12, and we're just finishing up cardiac now. I don't know if they have you come a little bit early, but I'm not the one that teaches the class. 11? Okay, yeah. RJ will probably be here in a few minutes. I think he's the lab lead. So you can hang out here if you want to, or in the hallway. We're just finishing up our lecture for cardiac before lab. No problem. Well, we're happy to have you here in lab in a few minutes. So yeah, hang out, grab a chair if you like. Sure. Sometimes the flutter waves are not so clear. Sometimes it's hard to see, especially if you have artifact in there. And I keep saying artifact. Artifact just is waves that are on top of your ECG, and there's patterns, we'll talk about it later, but waves on top of your ECG that make it harder for you to diagnose them, among other things, okay? If the patient's ventricular rate was 272, do you think that would perfuse? Very unlikely, but I mean, some VTAC rates up to, I think, 300 can perfuse a little and still have a little pulse. But what kind of pulse do you think you would generate? Carotid only, maybe? Yep. All right, let's look at some other. Now, they're not, as I mentioned, sometimes flutter is sometimes it's regular. Fib is always irregularly regular, but there should be a pattern present. Fib also, I'm not going to get to it today, but the waves for fibrillation don't look like this at all. They almost look like artifact, okay? So with this, we have a variable rate of AD conduction. So the AV node here is not doing as well of a job of saying, and maybe it's not the AV node's fault, maybe it's because of the underlying pathology, but the AV node rate here is not saying, okay, like we did see on the last one, no, 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 go through. It's varying in what it lets through, which results in an irregular ventricular rate. The atrial rate is still about regular. But now, in the atria is not controlling what's going to the ventricles, the AV node is, but the AV node is varying which things get conducted. So this can be irregular, but it'll often have a pattern because the AV node is still functioning generally well enough to let some of it through and not all of it. In this case, you wouldn't necessarily count the conduction ratio because it's variable. So you would just call it a variable AV conduction. But you can clearly see the flutter waves, right? The sawtooth pattern. So with this one, it would be A ventricular rate around 90. Yep. 300 for the other rate. Okay, so we don't talk a lot about the U wave, but they threw one in here for us. And again, for our purposes, the U wave comes from some specific abnormal presentations, usually associated with hypothermia. So if the patient's not hypothermic, it's probably not a U wave that's presenting for our purposes. But a U wave is basically an additional wave after the T. So we have our T wave, a U wave, and if you notice, look at these changes here. You see this, maybe hard to see on the screen, but see these changes where it's not exactly the same? There's a buried flutter wave occurring, but it's being covered by the overlying repolarization, or a buried U wave. So in this presentation, it's regular. Our QRS amplitude doesn't have a whole lot of S waves going below the line. This, I wouldn't consider this to be true depression. It's just coming back to the baseline. But this and third degree AV block, depending on how their P waves look in a third degree AV block, can look like an abnormal conduction ratio if you don't have a long enough strip. Because again, I'm going to say it over and over again, even though I haven't done AV blocks, but if you have an AV block, the atrial rate's this, the ventricular rate's this, there's no communication. But depending on what phase you look at, when you look at your ECG, they may be crossing over and making abnormal patterns. So you really can't use a 12 lead. You need probably even more than a 6-second strip to present that. Let's see. 400 sawtooth. There's no PR interval because they don't have P waves, so you don't measure the PR interval. So it'd be 0 on the Huff book. Let's see. That's cardioversion and then atrial fib. Okay. Okay. Let's just look at this for the purposes of, I believe like next week, your new lab, you'll start right away with like synchronized cardioversion and stuff like that, and statics and dynamics. I'm not sure if when you did it on the monitors, if you actually get to see what it looks like when you do this, because our mannequins, sometimes they don't give the feedback that it worked, which is why you wouldn't see this. But what you're seeing here is a patient that has atrial flutter. Patient has cardioversion. So this is the major cardioversion wave, and it was synchronized. We wouldn't generally use defibrillation. Stopped the heart, and when it restarted, it's a little funky looking, but we have more presentation of a sinus wave. This might be the patient like moving because their heart just got stopped. They're going to feel it. It's not going to feel very good. But this is what it looks like when you cardiovert the patient. If you use adenosine, you don't see that big waveform because this is the depolarization of the heart because of the energy we're using. And we're probably using a pretty considerable amount of energy compared to what the heart would generate. So it goes off the charts in the depolarization, flat lines, and then hopefully, it's always just a hope, hopefully the heart rate comes back. Okay, so you are defibrillating the patient in the sense of you're stopping the heart with electrical activity, but we're synchronizing it so we don't cause cardiac arrest. Okay, so sync cardiovert. So this is what it would look like to convert. If you used adenosine to convert this, and we'll talk about there's some very special things we have to think about for adenosine for flutter and fib. But adenosine, if you use it to cardiovert chemically, then you would just see kind of a flat line, and then hopefully it comes back. You wouldn't see the big depolarization waveform from the electricity because you didn't cause electricity, you caused their heart to stop with the chemical. All right. Cool, let's stop there. I'm going to talk about adenosine more in SVT, but so adenosine can be used for tachycardias. It's kind of a big class for tachycardias. We tend to use it for certain types of tachycardias, but it's not necessarily easy to say we don't use adenosine on AFib. We don't use adenosine on aflutter. That's not exactly the case. We try to make it easier for you to memorize that right now, but there's a specific waveform that you don't use adenosine on, or you will cause the AV node to stop working, and then they'll go into magical cardiac arrest. So I wouldn't put it in a box of just SVT. It could be used in other settings. But there's a particular waveform on a rhythm that we'll see, that we'll cover it with SVTs, that if it's on any other rhythm, you can't use it in general, okay? All right, so as you're going through this, AFib will just be irregular. The waves that are present are not P waves. We'll look at it again, but if you're going to work on this stuff before then, the rates are generally going to be faster atrial than ventricular, has the same terminology. If it's AFib and it's a normal rate, up to 100 beats per minute, then it's AFib. If it's 100 to 150, less than 150 beats per minute, it's uncontrolled. If it's above 150, it's a rapid ventricular rate. And again, rapid ventricular rate is just the description of the ventricular rhythm, the QRSs. Stable, symptomatic, and unstable, what we decide to treat on. So start looking at your treatment, because that's essentially what you're going to roll right into the next cardiac lab with. That's what I'm doing, I think, with Fast Track today. We're going to do some folks and see what happens. Well, some mannequins, I guess, but go from there. Questions?
Atrial, is this testable for the first exam?
No. This is all second exam. All second exam. All the measurements, parameters of the ECG, lead to all that stuff, but not these atrial rhythms. The first exam will, if it has sinus arrhythmias on it, it'll be verbally, but it doesn't have any visual. I don't think it has it on there. That's all second exam. So second exam will be full of ECGs and then some other questions and scenarios. All right. Have a good lab. Good luck today. All you got to do is pass. That's it.